Good morning, everybody, and happy Friday. And I just want to make a disclaimer. I am not a physician. My name is Beth Oliver. I'm the Chief Nurse Executive and the Senior Vice President of Cardiac Services, and it's truly my privilege to be here today to talk to you about something that's near and dear to all of nursing, and I hope our technicians' hearts are really having an understanding of what are the social determinants of health and how does that impact the vascular population. I'll start off with, I have no relevant financial relationships. I'm going to briefly talk about social determinants of health, talk about vascular patient demographics at the Mount Sinai Health System, and really the role of nursing. And when I say nursing, I'm not excluding techs, but our nurses, as you know, if you're in the procedure or you're on the floor, pre-procedure, post-procedure, and particularly at discharge, it is absolutely essential that you know that patient. And I'll get more into and really how nursing can make an impact. Certainly on social determinants of health, evidence clearly reveals an association between both the individual's health and their access to health care and social determinants of health. And when we talk about that, we're asking about what is the patient's educational level, how is their health status, their comorbidities, what is their neighborhood or their environment? Do they live in an area where there are food deserts, where they really can't get access to food? They can't walk because there's no sidewalks. All of these things that we probably thought it was the social worker's job is really now come into the fore, as we get more into team-based care, that it's not only the social worker, but it's also the nurse's role and nurse practitioner. What is their social community? Many of our patients are very active in their church communities, and their church communities are their families, providing meals, blood pressure screenings, etc., and really talking about the economic stability. Many of these medications are so expensive that it's so important that before we discharge them, can they afford them? And it's not just the script, because as you know, if you're a provider, the torture of dealing with the insurance companies for authorizations. So it's really important. I mean, we're really moving in the Mount Sinai Health System. I'm very proud that we're really focusing on this. Certainly the relationship between health and social determinants of health can't be stressed more. There's a distinct correlation. It really talks about, the social determinants of health, health outcomes, quality of care, as well as, more important, access to health care. And addressing these issues is absolutely imperative to eliminate healthcare disparities so that we achieve health equity throughout the nation, and that nurses play a key role. And when I say nurses, I mean nurses and advanced practice nurses and physician assistants, the advanced practice arena. But certainly, the higher the outcome, the better educated you are, the better neighborhood you come from, the better social status, you have better health, of course you have better access to health care, better health outcomes, better means to pay for your health care, and you're able to make more informed decisions. On the other side, lower income, inferior education, poorer neighborhood, worse social and physical environment really leads to poorer health, limited access to health care, worse health outcomes, poor quality of care, inadequate means to pay for health care, and less informed decisions. It's sort of intuitive, but I think it's important that we really talk about it. At the cellular level, the social determinants of health, somebody who is really struggling with those chronic psychosocial and environmental stressors that I've talked about, lack of food, lack of education, lack of money, can't get their meds, does cause at the cellular level, we know this, stress causes chronic inflammation. And certainly in the arena of vascular disease can increase progression and the development of that. Just to give you a little transparency of our patients, looking at about 4,100 patients in the Mount Sinai Health System, our vascular demographics. By the way, for every single one of our diseases in the last 2 years, we have an equity dashboard. And we also go over, for each disease, we go over this. We look at our we look at patients by ethnicity, and you can see that 29%, the largest is Hispanic, 32%, 29% are Black or African American, 28% white. We look at our vascular patient, we look at all of our demographics, but here are vascular patients by age. You can see that our 51% of our patients are between the ages of 65 and 84. And then followed 37% by the ages of 40 and 64. Average length of stay for vascular patients by ethnicity. We can see that Black or African Americans and other, who list themselves as other, or Hispanic, have a higher length of stay than, say, Asian and white. And vascular patients by ethnicity and readmission, we can certainly see that 15% are Black or African American, 14% Hispanic. And you're probably saying, well, like, who cares? Well, we do care because we want to make sure that every single one of our patients in the Mount Sinai Health System, and particularly our vascular patients, get the right treatment and get the right guideline-directed medical therapy, that we don't give to one and not to the other. And I'm very proud that we've done a lot of work on this area over the last 2 years. As a matter of fact, we've put equity as our health system, as our sixth health system value. Now I'd like to take a moment to really talk about identifying and addressing disparities among the vascular patients. And why is it important? Well, according to the research journal by the Seminars in Vascular Surgery journal, there's a striking variation in vascular care among population subgroups defined by sex, race, and ethnicity, and socioeconomic status, with related differences in preoperative medication optimization, who gets meds and who doesn't, who gets an amputation and who doesn't, and overall health outcomes. By understanding these differences, we're better able to make targeted interventions to improve health outcomes. So when we first look at the sex-based, we know that the major disparities exist between female and male patients in peripheral vascular disease, peripheral arterial disease rather. Female patients have a higher prevalence of depression. They're less likely to receive guideline-recommended high-intensity statin therapy, so please keep that when you're discharging the patients, and a higher rate of inpatient mortality. Targeted interventions, of course, is to screen all vascular patients, both men and women, for depression in the pre-op phase, and coordinating with, either psychiatry or social work or whatever to improve the medical therapies and their compliance. And emphasizing to all vascular patients the importance of really adhering to cardiovascular medications so that, of course, it'll slow the progression of peripheral arterial disease. And really ensure that vascular complication screening is done during preventive health visits, especially with women, since they are more likely to attend the visit, and it's essential for early identification. In regards to identifying racial and ethnic disparities, research has really shown that 30% of Black patients will develop peripheral arterial disease in their lifetime compared to 20% of white and Hispanic patients. Further, Black peripheral arterial disease patients often have a more significant comorbidity burden, and Hispanic peripheral arterial patients were found to more likely to delay their medical care due to employment or child care issues, and really less likely to adhere to cardiovascular medications. Continuing our commitment to a diverse workforce, as this will help improve both patient and employee engagement. We've done a lot of work as well that we represent our community, the community to which we serve. At Mount Sinai, we believe that a thriving workforce, first of all, starts with creating a diverse workplace. And I'm extremely proud of the initiatives that we've put in place to support diversity, equity, and inclusion across the health system. This commitment really extends beyond our recruitment practices and also includes efforts such as providing educational resources to our employees and improving, more importantly, the enrollment of underrepresented populations in clinical trials. The role, again, some statistics, and this is all from the Vascular Journal. Hospitalization is more than twice as high for individuals that make less than $12,000 per year. The risk of hospitalization was doubled if an individual received less than a high school diploma. Uninsured and Medicaid patients were more likely to undergo major amputation, whereas private insurance patients were more likely to undergo limb salvage procedures. And this is all, this is right out of the journal. Again, uninsured patients will need more assistance, as we know, and that's why, at Sinai we have, and I think, I have to go back now. At Sinai, in our EPIC, we actually have the social determinants wheel as part of the functional nursing health assessment. It's also in the case management, it's also in the social worker, and it's also at interfaces between inpatient and outpatient. It's that important to know your patient on all those levels. So if somebody is starting smoking cessation out in the outpatient practice and they come inpatient, you don't need to waste your time on that. You can reinforce it because it's already being done and you know that it's being done. We're trying to increase efficiency and really marry the inpatient and the outpatient so it's not two levels of care, it's the same patient and that we're all on the same page. Again, advocating anybody from podiatry, taking care of your feet, modeled used by the American Diabetes Association. And again, it says that we utilize, telemedicine to increase healthcare in patients with vascular disease and low socioeconomic status. But there are some patients that can't afford a computer. So we also have to get real on that and really look into that. And that's why I think it's really important that, our community involvement goes beyond Mount Sinai, that we're going to the community. And there is an agency, there is a team in the Harlem area that provides, because during COVID, many of the patients couldn't get out. They couldn't order groceries because they didn't have computers. So there was a campaign to get laptops for the patients. And so I think that's something that we should think about for some of our patients so that, again, we provide equitable, safe care and that everybody gets the same level of treatment. So in summary, really, the key takeaways are that the social determinants of health, it's not just a buzzword, it's reality. We use it in every disease that we take care of, but that gives us the whole picture of the patient because our goal is to take care of them and not have them come back and not come back within 30 days or come back within a week because one of these things that we didn't address. So really as nurses, education, employment, housing, access to healthcare, income and wealth, physical environment, transportation, and health outcomes are all so key to taking care of our patient. As nurses, and really going as advanced care providers, we are trained to consider the individual, the family, and the community in evaluating clinical interventions by advocating for patients, providing tailored patient education, and really supporting our patients in their ability to self-manage their health. And collaborating with our interprofessional colleagues and aligning resources with patient needs relative to social determinants of health can really enhance the patient care and health outcomes of our vascular patients. So thank you.